Good morning, everybody. Today we are talking all about constipation, so topic very dear to my heart. For those who don't know me, my name is Joanna Baker. I am a dietitian and a registered nurse. I specialise in IBS and food sensitivities, and I also started Low FODMAP Australia, so I started this group way back in 2017, just because I'd seen so much non-evidenced information about managing IBS and FODMAPs on the internet. And I really wanted to just get some evidence-based advice out there. I also wanted to provide a bit of support for my patients sort of in between appointments, because I know there's only so much that we can cover in an appointment. So being able to have a place where people can ask questions, where people can connect and not feel so isolated was also a really big part of why we started this group. So at the moment we are trialing a weekly Facebook Live, so where we talk about a different topic every Friday morning at 10 a.m. I usually try and keep it to about 20 or 30 minutes. Sometimes I ramble on a little bit longer. All of these are recorded, and I also pin them all to the top of the group. So if you're wanting to watch one again, it should be up there. Anyway, today is going to be all about constipation. If you have any questions, please pop them in the comments below. I will come down and answer any questions afterwards if they are there. Otherwise, just let me know, give me a thumbs up if you can hear me loud and clear. Let me know where you are, what's going on. I'm down here in Melbourne. It looks like it's going to be a nice sunny 23 degrees today, but all of a sudden tomorrow we're heading up to 37. So if you live in Melbourne, you'll know the weather is often a topic. So anyway, constipation. So today we are going to talk a bit about what is constipation. We're going to talk about some of the potential causes of constipation. We're going to talk about the overlap between FODMAPs and constipation, because there is a little bit of an overlap there as well. And we're going to finish off with some strategies of things that you can do to help with constipation, because that stuff is important as well. So, start off with, what is constipation? So constipation by definition is having dry, hard or infrequent stools. In terms of what would be considered normal for having a bowel movement, we'd be looking at anything from 3 times a day to once every 3 days. Within that realm is considered normal. However, from where I sit, what I'm more interested in is how comfortable you are when you do go. So if you're going once every 3 days and you're feeling quite comfortable, you're not having bloating and everything, you get the urge, you go and do your thing and life goes on, I'm more than happy with once every 3 days. If you are going every second day but you're feeling backed up, you're getting little pellety things that are really uncomfortable, that are really difficult to pass, if you're having to strain a lot, if you're feeling like you're not finished, then that's something that I am concerned about, and I do want to address. So it's sort of, I don't necessarily consider how often you're going, as long as it's within that realm of normal. What I'm more interested in is how comfortable you are when you do go within that realm. If you are going for more than 3 days without going, then that would be considered outside the realm of normal, and that would be something that I would be interested in as well. Once you get to going more than 3 days without going, I actually don't care how comfortable or uncomfortable you are. Then we're looking at potentially getting backed up and getting a bit impacted. So that would be something that we want to address as well. On that topic, you can go every day and still be backed up and impacted. And in fact, what we would call fecal loading, or having that colon full of stool, that's one of our biggest causes for things like bloating and gas and things like that as well. So you can go every day and still be backed up and still be experiencing that bloating and discomfort from it. So if that's something that is potentially an issue, and that's something that I would always screen for as well. I'm going to talk a little bit more about that in a minute. I'm kind of getting heading off on a tangent. Like I said, I can do that sometimes. So constipation, dry, hard, infrequent stools that are difficult to pass, feeling unfinished, going for more than 3 days without having a stool, having little pellety type things. That sort of falls under that sort of constipation umbrella. In terms of what causes constipation, there are lots and lots and lots of causes for constipation. We can have things like not having enough fiber in your diet. So fiber is the part of food that doesn't get digested, and it actually makes up the bulk of that stool. So if you don't have enough fiber in your diet, you will have quite small, hard stools. So that can be a cause of constipation. By bulking up the diet, adding that more fiber, and we get these bulkier, softer stools that are easier to pass. So low fiber can be a big cause of constipation. Dehydration can be a cause of constipation, and I actually look, the number of times that I'm seeing somebody and we get to that, how much water do you drink, and people say to me not enough, is just way too common. And the number of times that we increase that water and they come back to me and say, oh wow, I increased my water and that made a really big difference. It happens way too often, and I know sometimes it sounds like getting back to basics, but absolutely dehydration, not having enough water means that you don't have enough lubrication in that bowel, and it's much more difficult for things to pass through. Also, not having been dehydrated, again, ends up in quite small, hard, compacted stools, which are more difficult to pass as well. So making sure you drink enough water is important. Transit time. When we talk about transit time, we talk about, or gut transit, we talk about the amount of time that it takes for food to move through your mouth, through your stomach, through your small intestine, through your large intestine. And that's always on a spectrum. We have some people that naturally have a faster transit time. We have some people that naturally have a slower transit time. And that's why we would consider anything within once every 3 days to 3 times a day fits within that realm of normal, because there is a variation and there is a spectrum in terms of transit time. So heading towards that slower end of the spectrum can be a reason that we see that slow gut transit and we see constipation as a result. Ignoring the urge to go is a cause of constipation as well. It's important that when you get that urge to go, you actually go and act on that urge. The longer the stool sits in your colon, the drier it gets. So if you're holding on and you're ignoring that urge, as the stool is sitting there waiting to come out, it gets smaller and harder and drier. So ignoring that urge to go can end up in having constipation too. Changes in routine in terms of lifestyle and in terms of eating routines and things like that. Sometimes we can see the body sort of have a bit of adjustment, and we might see a little bit of temporary constipation if that happens. I know for myself, whenever I go on holiday, my gut slows down. Probably a bit of change in diet, probably feeling a little bit more relaxed, probably a bit of change in routine and things as well as having an effect on that. Also, another big one is side effects of medications. Any medication that you take through your mouth, or all medications have got side effects. There are literally no medications that do not have side effects, and that goes for supplements as well. Supplements all have side effects. Anything that goes through your mouth and gets absorbed through your stomach potentially has side effects that affect the gut, and can slow down gut transit and can cause things like constipation. So we commonly see this with things like our opiate-based pain medications, so things like endone, morphine, fentanyl, those sort of strong pain reliefs. They cause constipation. Some of our medications that we use specifically for IBS, so there's some anti-anxiety medications that tend to specifically target the nerves in the gut, so things like amitriptyline and nortriptyline, they have constipation as a side effect as well. So medication side effects can be a cause of constipation. In terms of when you want to be seeing your doctor, so we're in a FODMAP group here, and the majority of people in this group have IBS, and one of our flags for seeing a doctor is if you've had issues ongoing for more than 14 days. So if you've had ongoing gut issues for more than 14 days, it's really important to see your doctor. So anybody before they start a low FODMAP diet, before they're even diagnosed with IBS, we do want to be seeing your doctor, and we want to be screening for more serious or more physical causes that could be causing these gut symptoms. IBS and FODMAPs are not the only thing that causes gut symptoms. There can be some quite nasty things out there. We want to make sure that we exclude those and that we are heading down the right path. So if you've got ongoing symptoms, it's really important to see your doctor. If you have been diagnosed IBS and you are following an intervention to treat that IBS and you are not getting relief of those symptoms, then it would be important to see your doctor and probably see a dietitian as well. Again, FODMAP is not the only answer, and I will talk a little bit more about FODMAPs and constipation in a minute, because there is quite an important crossover there too. If you've got any unexplained weight loss, definitely want to be seeing your doctor. And if you've got any bleeding from the back passage, want to be seeing our doctor as well. So that is what constipation is, what is normal in terms of bowel movements, what our causes of constipation tend to be, the most common causes. So when it comes to IBS and when it comes to the low FODMAP diet, now FODMAPs, they go in through the mouth, they pass down the esophagus, they pass through the stomach, they pass through the small intestine and do not get absorbed in the small intestine. They continue to the large intestine or the colon, and once they've passed through the colon, they leave the body. Thing is, while FODMAPs are in the colon, they do two things that can cause IBS type symptoms. The first is they get fermented by the bacteria that lives there. That creates gas and makes people feel bloated. It pushes on those nerves around the gut, and it can affect how fast that pushing on those nerves can affect how fast or slow the gut is moving. The other thing that FODMAPs do is that they attract water into the bowel, and if we fill the bowel up with water, all that water's got to come out somewhere, and we see loose, watery bowel movements. Now, the thing is, when you go on a low FODMAP diet, you reduce the FODMAPs that you eat. If you reduce the FODMAPs that you eat, you don't draw as much water into your bowel. If you are going a little bit too strict for you on that low FODMAP diet, you can end up with a very dry bowel. And we can see people who have always been leaning towards the diarrhea end of IBS can suddenly end up down the constipation end of the spectrum because they have restricted their FODMAPs too much and their bowel is getting too dry, and and the stool is not getting enough. It's not enough lubrication there for the stool to pass through, so everything slows down. This is why FODMAPs a low FODMAP diet can be so effective for treating diarrhea and not so effective for treating constipation. Now, so obviously, if you're diarrhea dominant, you've suddenly become constipated from going on a low FODMAP diet, that's because you're drawing less water into your bowel. The absolute best thing to do then is to start adding back a few of those FODMAPs to find that balance between limiting them enough to keep you comfortable, but not limiting them so much that your bowel is getting dry. So we want to find that nice happy medium. Now, if you're somebody that has always been down the more sluggish end or the more constipated end of the gut transit spectrum or the IBS spectrum, I, as a dietitian, in my experience, if you are constipation dominant IBS and we put you on a low FODMAP diet, it helps with the gas and the bloating, but the constipation tends to get worse. And what we end up with then is completely backed up through the gut, and then all that bloating and gas and everything comes back because we're getting fecally impacted because the bowel is things are just not moving through the bowel so much. What we can see there as well is overflow diarrhea, where you've got this impaction or you've got that fecal loading through the stool, through the colon, and we've got all this loose watery stool coming around the outside. And that's something that this week I've seen 3 or 4 times already this week, where we've got somebody who's been fecally loaded and had diarrhea as a result of the fecal loading. Once we have cleared that fecal loading away, a whole lot of symptoms. And look, somebody who is constipation dominant IBS, I would never put them on a low FODMAP diet without first addressing the constipation and getting them using their bowels regularly, because I do find that once we get people using their bowels regularly, at least 50% of the time, the bloating and the discomfort actually goes away, and then they don't actually need a low FODMAP diet after all. So the first thing we would do is address that constipation. If we've still got symptoms after we've addressed that constipation, that's when we would actually then start looking at a low FODMAP diet again. If you are constipation dominant and we are using a low FODMAP diet, I would always add in extra strategies to stop that constipation getting worse from the reduced FODMAPs in your diet. So that's kind of where we get that bit of a crossover between low FODMAP and IBS and constipation. So what do we want to do about constipation? Because this is the real question. This is what we want to know, because constipation is super uncomfortable and we want to treat that constipation. So like I said, if you've been up the diarrhea end of the spectrum and you've become constipated with a low FODMAP diet, we want to bring some of those FODMAPs back into your diet. We want to start challenging, we want to start reintroducing and find that balance between enough to keep you regular, but not so much that we leave you running. In that instance, I would always focus on the more osmotic FODMAPs, because some FODMAPs are more likely to draw water into the bowel and some FODMAPs are more likely to create gas in the bowel. So the ones that are more likely to draw water into the bowel are the lactose, the fructose, and the polyols. So those are the ones that I would start with. If you are not ready to, actually I'll talk about that in a second. So yeah, we want to start reintroducing, bringing some of those FODMAPs back in and find that nice happy balance there. Now, if you are up the constipation end of the scale and you have become more constipated than on a low FODMAP diet, if you are not ready to start reintroducing yet, perhaps you've become constipated and you've got some ongoing bloating and symptoms there as well. Potentially because FODMAP may not be addressing your bloating, there may be something else that is causing it, or potentially because you've gone on a low FODMAP diet, you've become constipated and the constipation has then started causing the bloating. It can be really tricky to start reintroducing when you've got those things going on. So what we would start with, what I kind of separate this out into, is that we have food strategies, we have behavioral strategies, and we have supplements that we can use. So in terms of food strategies, the first thing we want to do is we want to be reviewing your diet. We want to see, are you getting enough fiber and are you getting enough water? Because those two things are priority in terms of getting regular bowel movements. And I would say that fiber supplements are probably the supplement that I use the most often in my practice. So check your diet. Are you getting enough fiber? Are you getting enough water? Do we need to increase that? In terms of fiber, as it goes in one end, passes through and comes out the other end. As it goes through, it acts like a sponge and it soaks up water. So if you increase your fiber but don't increase your water, it doesn't work for constipation. We need to increase both, because that fiber will soak up the water and the fiber will become a bulky, soft, easy to pass stool. So fiber and water together, they need each other to work. In terms of high fiber, low FODMAP foods that we'd be looking at, definitely things like your nuts. So not your cashew nuts and your pistachios, but things like peanuts, macadamia nuts, Brazil nuts, walnuts, almonds have got a low FODMAP serve. So those are all your nuts. Those are a really great source of fiber. Absolutely, oats are a brilliant source of fiber. We've got seeds, things like pepitas, sunflower seeds, chia, linseeds, flax, those sorts of things. Really awesome source of fiber. We have also got our low FODMAP legumes. So our canned chickpeas at quarter cup serves, small serves of canned lentils, small serves of butter beans. Now, these things pack a punch in terms of fiber. Yes, your fruits and your vegetables do have fiber in them, but they don't have nearly as much fiber as what we see in things like nuts, seeds, legumes, whole grains, those sorts of things. So those are really the crux of where we want to be getting our fiber from. And in terms of a low FODMAP diet, a lot of our high fiber foods are also high in FODMAPs. And often when you go on a low FODMAP diet, your fiber intake does decrease, and it can be tricky to get enough fiber on a low FODMAP diet. So making sure that you're including some of these high fiber, low FODMAP foods in your diet and drinking enough water can be super, super helpful and can be life-changing. So if you are using your low FODMAP breads, rather than going for the gluten-free ones, which are lower in fiber, go for your sourdoughs. They're higher in fiber. If you have celiac disease as well as IBS, so you need to use a low fiber bread, a gluten-free low FODMAP bread, then look for one that's got plenty of seeds in it, things like your Helgas, soy and linseed. Those are a really great source of fiber as well. Include your whole grains, so your quinoa, your sorghum, your oats, your buckwheat, your millet, your spelt, your sourdoughs. Those are some really great sources of fiber to be getting enough fiber. Obviously, fruits and vegetables, 2 fruits, 5 veggies a day. I can't say that enough. Only 92% of Australians in our last National Nutrition Survey reported that they were not eating their 2 serves of fruit and 5 serves of veg a day. So we've actually only got 7% of us that are eating enough fruits and vegetables. So we can all add in an extra piece of fruit or an extra vegetable into our day. Kiwi fruit. If you've been in this group long enough, you will know, you would have heard us talk about kiwi fruit. Kiwi fruit is absolutely amazing for constipation. It has an enzyme in it called actazin. That actazin enzyme actually encourages the muscles around the bowel to contract and push stuff through. So kiwi fruit can be absolutely magical for addressing constipation. So 2 kiwi fruit and see me in the morning. We do also, there is a kiwi fruit supplement called Flow. I see that pop up in the group every so often. Now, I don't usually recommend Flow on a low FODMAP diet because it does have mannitol in it, which makes it high FODMAP. So we want to, before we go addressing those, start bringing in things like that, we really want to know what your mannitol threshold is. Otherwise, we're on a low FODMAP diet, but we're taking high FODMAP supplements, and it kind of counteracts each other, and we end up not knowing exactly what's going on. If you are somebody who is actually taking Flow and getting a good result with that, then obviously you are okay with mannitol. And in that situation, I would say, hey, why don't we try some of these higher mannitol foods and see if we can bring those back in, because it sounds like you actually tolerate mannitol quite well. The other thing that I often use for constipation in terms of food is coffee. Coffee is a natural stimulant, and it does stimulate that gastrocolic reflex. Now, that gastrocolic reflex is strongest in the morning, so that first hour or two after you get up in the morning. So getting up, having a coffee first thing in the morning, that can often be enough to stimulate that bowel movement and get it moving and get it happening. So that can be super useful as well. So those are our food strategies, our behavioral strategies. And again, I can't say this enough, people that use a mix of strategies tend to be the ones that get the best results. So you think about your food. Do you need fiber? Do you need fruit? Do you need vegetable? Are there some whole grains that you can get in there? Is coffee the right thing for you? Is kiwi fruit something that you're ready to add in? Or are you somebody that wants to add back some of those FODMAPs? The next thing is we want to think about our behavioral strategies. So exercise is great. Exercise is really good for digestion and helps things move through. So making sure that you're getting out for a walk and you're moving your body. I don't care what exercise you're doing as long as you enjoy it, because if you are moving your body in a way that makes you feel good and you're enjoying it, you're more likely to be consistent with it. And when it comes to exercise, consistency is far, far, far more important than what you are actually doing. So pick something you enjoy and move your body in a way that helps you feel good each day. So that's really cool as well. Posture is a really important one. And you've probably seen people talk about having a footstool in the bathroom as well. Now, the thing about us Westerners is we have this toilet where we're sitting in this sort of right angle position, your back sitting on the stool. What happens, I actually haven't got a picture here, but I'd love to have a picture to show people, but there is a muscle that slings around the back of the rectum. So when you've got your colon, goes ascending colon, transverse colon, descending colon, then we've got this little dog leg that comes around to the rectum, and then the anus where the stool comes out. Around the rectum, there's this little muscle that sort of slings around the back. And when you're standing up, that muscle is kind of pulling it up tight in a bit of a kink. And that stops you needing to go to the toilet all day, every day. So it keeps the stool inside while you're standing up and walking around. The thing is, when you're sitting in this right angle position, that muscle is still pulled tight. So it's not the ideal position for passing a bowel movement, because you've got this muscle pulling tight and pulling in against the rectum, and it's difficult to push past. So if you have a look at some of the Asian communities that have the squat toilets, or if you have a footstool that raises your feet off the ground, where you've got your back and your knees, bring your knees up so you've got this more of angle on here. It actually releases that muscle that's slung around the back of the rectum and makes it sort of more aligned in terms of passing that stool through. So having a footstool in the bathroom can be really, really useful. So that's a good trick as well. If you haven't got a footstool and you just want to sort of improve that angle a bit, you can try lifting your heels up onto your toes and leaning forward, and that can increase that angle, or decrease that angle as well, to get that alignment correct there. Having a routine with your toileting is really cool as well. The body likes routine, and the body likes to know what's happening next and what's going on, because then it doesn't get any surprises and it knows what to do. So having a routine where perhaps you get up in the morning, you have a hot drink, you have some breakfast, you go and sit on the toilet, and then you sort of carry on with your day. And doing that each day actually teaches your body that that's when it's time to have its elimination. My son would kill me for this, but it's his 15th birthday today. So his routine is after dinner, and it's been since he was a tiny little kid. Since he was first out of nappies, he's had this routine that after dinner, he gets the urge to have a bowel movement and he goes and sits on the toilet. So every night after dinner, he goes and sits on the toilet. And my husband gives him a hard time that it's because he's trying to get out of the dishes. Maybe that's how it started, but either way, his body has learned that routine. And now as long as he runs with that routine, everything works smoothly and he is very comfortable. Personally, I prefer a morning routine because I like to get things out of the way, take care of business before I carry on with my day. But whatever your routine is, whatever suits your lifestyle, getting into some sort of routine can be really, really helpful for having your body know what it's supposed to do, when it's supposed to do it. It likes to be able to predict that. In terms of behavioural strategies, you can also see a pelvic floor physiotherapist. They've got some really great strategies in terms of breathing, in terms of massage and that sort of thing that can help with having that bowel movement. There are certain situations, certainly people who've got a bit of a cardiac history, if you work on the cardiac wards in hospitals, you'll see above all of the toilets no straining. So if that's the situation and you're struggling with that straining, it can be really helpful to see a pelvic floor physio because they've got some really great techniques and there are some really good tricks up their sleeve to help with passing that bowel movement too. Finally, our supplements. I always start our supplement section by saying that this is not personalized advice and we will always recommend to speak to your doctor or your dietitian or your pharmacist before making any major changes to your routine. So the supplements is really for educational purposes only. In this forum, I don't know you, I cannot say what's right or wrong for you. But we obviously have our fiber supplements, and if you want more information actually on supplements and medications, there is a video pinned to the top about supplements and medications for IBS, and I go into quite a bit of detail then, and I talk about a lot of these supplements for constipation too. So we have got our fiber supplements. Again, they are, as long as you're having enough water with your fiber supplement, they are really good for adding bulk to the stool and making it easier to pass the bowel movement. The ones that I use most often in my practice, I use K-fiber, I use psyllium, I use PHGG. I do have some people that use other fiber supplements like Benefiber and things like that. They just don't tend to be my initial go-to. But with fiber supplements, they can be, people's bodies can be a little bit finicky about them, and it can be a bit of trial and error with different ones to find out what's right for you. And I will often have a bit of a discussion with somebody about their situation before I say which fiber supplement is right for their situation. But generally, I'm using K-fiber, PHGG, and psyllium in my practice. If you've got one that you've tried before that you've had a really great result with, that would be the one that I would start with as well. Magnesium. Magnesium has osmotic effects, so very similar to FODMAPs. Magnesium draws water into the bowel. So in some situations, we might use magnesium to help with constipation. We'd be looking at doses of around about 400 to 600 milligrams, magnesium citrate being the most effective. Take that in the evenings. It draws water into the bowel, and we often see that will then lubricate the bowel, and we'll see a result the next morning. On that same vein, we've got things like Movicol and Osmolax, which are also osmotic laxatives that work by drawing water into the bowel and lubricating it. These are suitable for long-term use. They can be very, very effective for addressing constipation. They are not habit-forming, which is great. We also have, there are also some other laxatives as well, things like Senna and Caloxyl, and these are what we call stimulant laxatives. Now, I would never recommend a stimulant laxative for long-term use because stimulant laxatives do tend to be habit-forming. So those are more for your acute short-term constipation. So say you have an operation or you have an injury and you're taking very strong pain relief and you're getting constipation because of that pain relief, then we would be looking at a temporary stimulant laxative to get that moving again. And actually, just then as we're on that topic, if you have got medication-induced constipation, medication-induced constipation tends to be because the medication stops the bowel contracting. So if it doesn't contract, it doesn't push anything through. In that situation, fiber usually will just worsen the situation because it would just add to the bulk of what's sitting in your bowel and not going anywhere. In that medication-induced constipation, we'd be looking at, if it's a short-term thing, maybe something like Senna and Caloxyl. If it's a medication that you're going to be on long-term, then we might be using something like Movicol or Osmolax to address that constipation and get things moving through. So those are my strategies. We have talked a lot. I've talked for half an hour now. But finally, if you are struggling with constipation, you can try some of these strategies, try some of these things. If you have already tried all of these things and they're really not doing the trick, please come and see us, myself, Liz, Jasmine, and we have got Gemma, who's going to be starting up in a couple of weeks as well, who I'll introduce you guys to as soon as we are organised with her. We all specialise in IBS, we all specialise in food sensitivity and gastrointestinal nutrition, and we are more than happy to work with you to get you more comfortable, get those bowel movements moving through. FODMAP is the most well-known treatment for IBS, but some people, FODMAP's shown to work for about 3 out of 4 people, so that 1 out of 4 people that does not get a result with a low FODMAP diet, there are other diets that we can try. And the reason that I'm sort of mentioning this is often I find that when somebody is diarrhea dominant IBS, we use a low FODMAP diet. Oftentimes if somebody is constipation dominant IBS, that's often a flag for me to consider another diet instead, that we tend to get better results. Well, I've tended to get better results with in terms of constipation. Obviously, that wouldn't be the only reason for using a different diet. There'd be a few things that would go into that decision, but absolutely, we can chat to you about what is right for you in that situation, and we're more than happy to help. It doesn't look like we've got any questions here at the moment, so I will let things be, and I hope everybody has an amazing weekend. If you do have questions after the fact, please pop them in the comments below and I will come back and answer them. If you've got any suggestions or anything that you'd like me to talk about at next week or in future Facebook Lives, please let me know. I am always looking for more topic ideas. Have a great weekend. See you. Bye.